Hello, my friends. It's good to be with you today. Um, I have the opportunity to share the presentation today, and I'm going to talk about preventive cardiology. Just want to make sure my mic is on. So in 2023, I was invited to speak to a large group of physicians that belong to a continuing education platform called the Karazian Institute. And so I spent a year preparing a slide deck that talked about neurodegenerative disease. And when I finished that presentation, it was very well received. And the director of that institute called and said, Randy, we want you to do another one. What would you like to talk about? Well, at that time in my practice, I had had a friend that had a heart attack. And I thought, I had heart on my mind. I had cardiology on my mind. And so I just kind of blurted out this answer. I want to talk about preventive cardiology. And he said, great, we'll see you next year. So I spent entire 2024 preparing a presentation and a slide deck. For those who haven't done presentations before, it takes a lot of work to put together new slides, do the research, try to perfect it, which trust me, they're never perfected. But in July of 2025, so this last July, it's just been maybe 4 weeks ago, I gave this presentation. It was a 5-hour series of lectures about preventing cardiology, how to make it comprehensive and integrative at the same time, how to reduce risk. So I want to start out by telling you an experience that I had when I opened an urgent care clinic. This was in about 2012. I owned urgent cares and I was opening my third urgent care and I was the practitioner at that urgent care. And I met a museum curator. Now, this is not her picture. This is just a cut and paste off the internet. But she kind of had this look. She was a museum curator. She was in her early 60s, just as sweet as the day is long. This lady was good to the core. And when she came to my urgent care, her chief complaint was she had this intermittent heartburn that was totally unresolved with over-the-counter acid reflux medicine. Now, that should have been my first clue. She said, I've tried Pepto-Bismol and I've tried Pepcid and Zantac and I've tried all of these over-the-counter things. And man, I just have this low-grade heartburn. Sometimes it comes with a little bit more aggression. Sometimes it doesn't, but I don't, it doesn't, it's miserable. Can you help me with that? I think I need a prescription. Now, she was not yet Medicare eligible, so she must have been under the age of 65, somewhere between 62 and 65. So she was very guarded about the cost of health care, and she was restrictive to doing any testing. So she basically came in and said, look, Randy, these are the symptoms I have, but you can't do any testing because I don't have insurance and I can't afford it. She ran the Fort Hall Museum here in Pocatello. And so I thought, well, PPIs, these are the purple pill. This is omeprazole. These are the medications that everyone uses for acid reflux. So I said, well, let's start a PPI. And I don't remember which one I tried. I put her on one of them and recommended she make some dietary changes and then I would see her back. Well, she came back after about a week and she said, man, that just didn't do anything to me. Is there another one that I can use? So I gave her a second one and I raised the dose. And I said, hey, let's also give you a GI cocktail. Now, a GI cocktail has viscous lidocaine. If you've heard that term before, lidocaine is the medicine that numbs things. So I made this little shot glass and I put some numbing medicine in it and I put some belladonna and I put some Maalox in it and we stirred it up. It's this nasty little cocktail. It's very common. Everyone calls it a GI cocktail. And when you swallow it, it goes down the throat and it numbs the acid reflux. Okay? So I gave her that GI cocktail. She left my office and thought, yeah, I think I feel a little bit better. And I said, look, I want to see you again on Monday. I want you to come back and tell me. I'm not going to charge you for anything. Just come back. I want to make sure I'm starting to get spooked that maybe we're missing something. And sure enough, Monday morning, I got a call from the coroner that she was found dead on her toilet. Apparently, she got up in the middle of the night, maybe had some GI distress, sat down on the toilet to use the restroom, and had a massive heart attack and died. Now, the reality is, I recognize that she was probably having a heart attack for a month. She was probably having this slow burning GI pain that she interpreted as acid reflux. This is very, very common. In fact, in women who are menopausal, the primary symptom of a heart attack is upset stomach. It's not crushing chest pain. It's not, oh my gosh, I feel like an elephant sitting on my chest. For some reason, the way that the nerve endings work in women, their physiology is that they get acid reflux or they get belly pain when they're having a heart attack. I was absolutely mortified. This was the first time in my experience where someone that I had directly taken care of died within 2 days of my consultation. And I was mortified. It messed me up for a solid year. I wondered, oh my gosh, what did I do wrong? What did I miss? What could I have done different? And then, of course, they did the autopsy, and it revealed that she had very severe atherosclerosis and that she had suffered an MI, probably had been suffering that MI for about a month. Well, I signed her death certificate, and I vowed I would never let that happen again under my care. And I was able to look back and think, here's all the things I could have done differently to help this lady. So I want to talk about those. What do I do differently now? The first one is I have a very proactive, comprehensive cardiovascular risk reduction program. And that's what I'm going to introduce to you today. That's this preventive cardiology approach. It's a series of questions and a series of instructions that I give to patients to help them. The next one is I never blow off the imminent signs of a risk. And so when someone comes in with chest pain or chest discomfort or acid reflux, anything in this area, I just say, yeah, let's get an EKG today. I want to see what's going on inside your heart. Now, what if they say, I can't afford it? I'll say, well, then good. I'm not going to charge you for it. But when you walk out of my office, I have to know you're not having a heart attack. I've made that mistake before. The next thing is I stratify risk. It's very different when I have a 22-year-old with no past medical history come into my office and say I have acid reflux after I just ate fast food. That's very different to me than when I have a 62-year-old woman who's had slow burning chest pain and acid reflux symptoms for the past month that are unresponsive to over-the-counter medicine, because you have to determine plausibility. Most 22-year-olds don't die of a heart attack, but many 62-year-olds die of a heart attack. So then you have to think that's very reasonable in this population. And the third thing is I'll differentiate between primary and secondary intervention. Secondary prevention is when someone already has known heart disease. Like what if they come in and they say, hey, I had stents placed 10 years ago and now I have heartburn. Whoa, if you had cardiac stents, I am looking for chest pain at every corner. That's also very different than someone says, I have no cardiac history, my cholesterol has been really good. I had a coronary artery calcium score. I don't have any history, and I have this chest pain. I have a cough, right? So that's different. I'm separating primary from secondary prevention. The next thing I do is I always do in-house screening tests. These in-house screenings have gotten so good. I can do an EKG in 5 minutes and look at someone's heart. In fact, I got to tell you an experience. Just this week, my wife has been complaining of a palpitation. She's been complaining that something isn't quite right. She's had these palpitations. Now, she's had allergies like crazy. My wife is now 51 years old, and she says, Randy, I've had these palpitations every night. And I said, let's run down to the clinic and get an EKG. Like my threshold for testing is it's a lot lower now. So I just ran her down to the clinic. We did an EKG. EKG looked perfect. I sat and looked at her tracing for 5 minutes. And now we can do lab tests, right? We can also look at a troponin score or cardiac enzymes. Excuse me. The next thing I do differently is I establish a plan or a roadmap, if you will. You guys are all familiar with that term, that offers a multitude of solutions to prevent cardiovascular disease. And that's what I'm going to introduce today. It's this really preventive plan. When I feel like this gives my clients a sense of control, it helps them to decide how aggressive they want to be, how quickly they want to work through that. Like, do they want to do all the lab testing in one visit, or do they want to read about that and go online and look at AI engines and then come back to me and say, hey, let's look at a uric acid level, or let's optimize my hormones today. Let's decide that. And so my goal is to empower my clients with a home-based intervention. And if you've met me, you know that I always start with lifestyle. Lifestyle absolutely matters. And lifestyle in neurological disorders or dementia, or lifestyle in cardiovascular disease, it is the same. Okay, so I want to define cardiovascular disease in the first place. You guys have heard me say this a couple of times today. What does it mean? What am I talking about? Cardiovascular disease can be disease of the heart muscle. So it can be a little bit of congestive heart failure or a dilated, enlarged cardiomyopathy. Cardiovascular disease, we can be talking about the blood vessels. So what does the circulation to the heart or the circulation in the heart look like? And does an individual have plaque buildup? Cardiovascular disease could be defined as you have a sick rhythm, meaning that as your heart beats, you're more likely to have an irregular rhythm like we would see in atrial fib, or maybe you have runs of supraventricular tachycardia. Maybe you have a flutter or bradycardia. So the rhythm matters. And heart disease can also be a disease of inflammation. Oh my gosh, you guys hear me talk about this all the time. Inflammation, inflammation. You could have inflammation in your liver and it leads to cardiovascular disease, or inflammation in your teeth. You can have dental problems and it leads to cardiovascular disease. If you have autoimmune disease, it can lead to cardiovascular disease. So anything that drives inflammation and affects the actual muscles of the heart, or it affects the rhythm of the heart, or it affects all these inflammatory pathways, then all of these could be considered cardiovascular disease. So you see how broad it is. We have a very broad definition of cardiovascular disease. In 2021, a study was released called The Global Burden of Disease, and they looked at the leading cause of death worldwide. Well, guess what? Number one on the list is ischemic heart disease in 2022. Number three on the list was stroke. Now, this is a worldwide global burden of death. Okay, now they're projecting that in 2050, so 27 years from the time that this study came, they're projecting that the number one cause of death will still be heart disease and stroke will move into number two. Now, that doesn't give us a lot of confidence, right? This is the number one killer, and we don't even know how to slow it down. It's still projected to be the number one cause of death. Amazing. Okay, this is from the CDC, Centers for Disease Control. This is the age-related cause of death for the 10 leading causes of death based on age. And look at this. What's number one? Heart disease. So it's not just a worldwide burden, it's a burden here in the United States. Number one cause of death in the United States. This is 2023. Okay, so what in the world do you do? Well, that's easy, Randy. You go get your cholesterol checked. You got to know your total cholesterol and that formidable LDL. Ooh, you got to know your LDL because that's a predictor of heart disease. But now you're starting to see people all across the country are looking at SDLDL, oxidative LDL, LP plaque 2, LP little a, LP large a, lipoprotein B, myeloperoxidase. Look, there's a ton of discussion going on about cholesterol. And we look at what's considered high cholesterol and low cholesterol and borderline cholesterol. But did you know that cholesterol markers are a terrible predictor of heart disease? Let me say that differently. You can have a perfect cholesterol level and have raging heart disease. Or you can also have a really high cholesterol level and no heart disease, right? So there's a problem with looking at cholesterol levels. I want to give you an example of this. When we look at risk factors, this comes from the Journal of Circulation. This is the journal that's put out by the American Heart Association. When we look at the journal of or when we look at the risk factors for heart disease, cholesterol is listed as one of the risk factors. Okay, you see that down here on the bottom. But look at all of these other risk factors that are predictors of whether or not you're going to die of the #1 cause of death worldwide and in the United States. Do you get enough sleep? Are you eating a healthy diet? Are you physically active? What's your blood sugar? My gosh, this feels like I'm lecturing in brain disorders or neurodegenerative diseases. It's very similar. Are you a smoker? What's your blood pressure? What's your weight? These are all predictors of cardiovascular disease. So I want to talk about predictive risk for a second, and I'm going to wax a little clinical with you. Okay? How do we know that someone is at high risk? Well, in medicine, we look at a hazard ratio. A hazard ratio is a statistical measurement that compares the risk of an event in two different groups of people. Usually, when we're running clinical studies, we look at the risk of a group that is on a placebo. They're not receiving any treatment, but they don't know that, right? We're giving them a treatment placebo. And then we look at the risk of an event of a group that's receiving the actual treatment. And we compare those risks. It's a ratio, okay? So we call it a hazard ratio. So here's an example of what this looks like. So in the red graph going down, if I start with 100% survival, people who don't have any risk. And then I give them a treatment in red, and as they treat, people start having disease. Then we know, okay, did that treatment work? Well, we don't know because people got diseased. But if you look at the other column, that control group, these are people who are not receiving treatment. They receive no treatment. They're on placebo. And if you look at the survival rate, the group that doesn't receive any treatment are dying quicker. So as time goes on, there's more death, there's more disease over time. So this is how we track hazard ratios. So in a hazard ratio, the way we interpret it is we look at the event rate. Is the event rate, the event is the disease process that we're measuring, it's the outcome. Is the event rate the same in both groups of people? If it's exactly the same, the hazard ratio is 1. They're equal, they're no different. If the rates are lower in the treatment group, the risk went down, it's a less than 1. If the rates are greater in the treatment group, that means the treatment doesn't work. The treatment's injuring people, it's hurting them. Then the hazard ratio goes up, okay? So that's just kind of talking about statistics. So now I want to give you an example of what we look at for risk reduction. You'll see that this article was published in 2005. I graduated with my master's degree and became a nurse practitioner in 2004. So this was the clinical study. This was the article and the treatment summary that I was reading when I was finishing graduate school and entering my clinical practice to save lives. Okay? It was called the Adult Treatment Panel 3, or ATP3, and it was the guidelines for preventing cardiovascular disease. Now, I want you to pay attention to this. This picture right here of my little boy, Wade. Wade was born when I was defending my thesis. The very day that I was giving my thesis defense, that little boy was born at Bannock County Hospital. So I always remember graduate school based on little Wade, okay? My entire focus in graduate school was on LDL cholesterol. Man, this was the gig. And they classified high risk, moderate risk, or low risk. And you know how they classified that? They classified it based on your cholesterol level. So what was your LDL? Was it high or was it low? I want you to know we don't do this anymore in cardiovascular prevention. We don't talk about high, moderate, or low when it comes to starting cholesterol lowering medicine. I'll talk about that as we get a little bit further into this lecture. So again, this was the National Cholesterol Education Program, or ATP3 guidelines. And that was the study that I just showed you. And it was the original study was published in March of 1997. The revised guidelines that I just showed you were in 2005. But this is what consumed me while I was in graduate school. But when we look at risk factors for cardiovascular disease, we're not just hyper-focused on cholesterol. Remember, we look at the odds ratio of other risk factors. So I want you to look at this. If you have high blood pressure, the odds ratio is somewhere between 1.5 and 2 times, 2.0. Now, it kind of depends on what your blood pressure is, right? If your blood pressure isn't that high, then obviously the odds ratio goes down. But if you compare that to bad cholesterol, if you look at your cholesterol somewhere between 1.3 and 3 times higher, blood pressure is 1.5 to 2 times higher. Well, obvious in cholesterol, it depends what we're looking at. There's a lot of ways to look at that, right? And so this is kind of a linear relationship. As that goes up, maybe the predictive risk goes up. Look at smoking. It's more than all of those. It starts at 2 times the risk and goes to 4 times the risk on a hazard ratio. So smoking is the kiss of death for cardiovascular disease. You do not want to be a smoker. How about sedentary lifestyle, my friends? Look at that. The hazard ratio of a sedentary lifestyle is 1.5 to 2.4. That is as high as cholesterol. If you're a couch potato, you're going to have chest pain. If you lay around on the weekends as an armchair quarterback and watch NFL football, you're toast, right? If you're a diabetic, look at diabetes, 2.0 to 4.0. That has a much higher hazards ratio than cholesterol does. We need to be paying attention to when your blood sugar is elevated, when you have insulin resistance, right? How high your A1C is. It makes a difference. Obesity. What if you're just overweight? 1.2 to 2.0. Unhealthy diet. Well, first of all, I don't have a hazard ratio because no one in America can define what an unhealthy diet is. I'm pretty good at defining it. I can tell you what an unhealthy diet is, but in the research, we don't know. There's so many different models for predicting what an unhealthy diet is, they can't quantify it because it's not the same from individual to individual. How about non-modifiable risk factors? Everything on the left-hand side of your screen is modifiable, meaning you can quit smoking. You can lose weight. You can change your diet and lower your blood sugar. You can modify that risk factor. But the non-modifiable risk factors are, I can't turn back the clock of time. I can't change my age ever. I can't change my sex, even though in our society currently everyone thinks you can. No, you can't. You're either male or you're female. You can't change your family history, and you can't change your ethnicity, right? I'm Caucasian. I'll never be different. And so that's my ethnicity. These are non-modifiable risk factors. These are modifiable risk factors. So we have to pay attention to those. So this took me a lot of time. I want to go back and show you how the cholesterol guidelines have changed since I graduated in 2024. So right here, 2004, sorry. This highlighted area, these were the guidelines when I graduated, okay? And so the target was all focused on LDL cholesterol. And we classified it as really high, moderate, or low risk LDL. And then we gave them numbers. So we said, if your LDL is high risk, we want your LDL less than 100. We're going to treat you to push that LDL super low. If it's moderate risk, we don't have to be as aggressive with cholesterol lowering medicine. And if you're kind of a low risk, then even then, we don't have to be super aggressive. In the super aggressive model, even in 2024, the LDL was pushed as low as we could get at less than 70. My goodness, that usually comes with some adverse side effects. And then obviously on therapeutic lifestyle changes, that's what this TLC means here, therapeutic lifestyle changes. We talked about changing people's diets, and primarily in 2004, it was eat a low saturated fat diet and increase your fiber. We want people to be physically active and exercise. We want them on a weight management program, and we're trying to control for insulin resistance. And the drugs of choice were statins or bile acid sequestriants. Okay, I'm not going to get into what bile acid is. It's things like fenofibrate or tricor, Zetia, and so forth. Okay, so these are these medicines to do that. Well, let's move on. 2013, the American Heart Association updated their clinical guidelines of how to prevent heart disease. The first big change is they shifted away from looking at LDL. That stopped being the focus. Do you know why that stopped being the focus? Because it wasn't very predictive. Someone could have a massive heart attack and go to the emergency department and their cholesterol is perfect. In fact, I think statistically, 50% of all heart attacks occur in individuals whose cholesterol is perfect. It's very low. So we shifted away. The American Heart Association says, well, this isn't really a good predictor of heart disease, so we're not going to be focused on what your LDL is. And they shifted the focus to risk factors. Okay, so you remember that slide where I talked about, are you a smoker? Are you overweight? Are you diabetic? Are you a man over the age of 65 years old or a menopausal woman? Do you have a stationary lifestyle? That's where it came down to. The American Heart Association says, okay, since cholesterol is not a big predictor of heart disease, maybe what we should do is start predicting heart disease based on risk. What is people's lifestyle? And they shifted their focus of cholesterol lowering medicine to statin intensity, meaning that we know that certain statins are more intense. They do a better job at dramatically lowering blood sugar. Other statins aren't as good. They're kind of crappy drugs, right? And it's so fascinating to me that the high intensity statins sometimes are not even covered by insurance until you get prior authorization. It seems goofy to me. Okay, so no longer in 2013 were we targeting LDL. That was not the target. We still continue to encourage people to lower their saturated fat, increase their fiber, get physically active, lose some weight, and control diabetes. That was still a focus. But we became very focused on giving statins to everyone because we no longer focused on your cholesterol level. It was all focused on risk factors. So guess what? If you're a diabetic, you get placed on a statin. If you're a man whose parents had heart disease and you're 60 years old, you get a statin. If you were ever a smoker, you're on a statin. If you are a little bit overweight, you get a statin. This is why every time you go to the doctor's office, they say you need to start a statin. In 2018, the American Heart Association, or the ACC stands for the American College of Cardiology, reaffirmed their guidelines from 2013. And they said everyone needs to be on a statin based on risk factor. And the focus shifted. And we now no longer even target LDL. We look at LDL to see how you're responding to treatment. Like, does the statin actually lower your cholesterol enough that it makes a difference? That's why we check cholesterol, but we still focus on risk factors and we focus on risk enhancers now. Risk enhancers would be how early are people getting cardiovascular disease, right? So maybe we could make our testing a little bit better to say, wow, you have cardiovascular disease in your 40s. That's a risk enhancer. Do you have chronic kidney disease? According to this model, my son who had a kidney transplant would be on a statin in spite of the fact that he's only 27 years old because he has a risk enhancement of chronic kidney disease. Or do they have other inflammatory conditions? An inflammatory condition would be rheumatoid arthritis, or you've had gout a couple of times. That's a risk enhancer because those are very inflammatory disorders. So if you have a very inflammatory disorder, by golly, you better get placed on a statin so we can intentionally lower that cholesterol level. Now, one added change that I love in 2018 was they added a recommendation for a coronary artery calcium score. Isn't that awesome? Now we're starting to increase our diagnostic tests. Since LDL is not that diagnostic of a heart disease, remember, you can have a heart attack and have perfect cholesterol. But if you have an elevated coronary artery calcium score, that is predictive. And I'm going to show you some research, probably in a future lecture, about the predictive value of a coronary artery calcium score. And it's interesting, the American College of Cardiology and the American Heart Association said, we do this testing if your patient is hesitant to start a statin, because now we can convince them, hey, look, you have known heart disease, you're getting these calcium buildups in your vessels, so lower your statin, lower your cholesterol levels, and let's put you on a statin. So these guidelines are still very statin focused, and now we're looking at synergistic roles for other medicines like ezetimibe, PCSK9 inhibitors, which, my gosh, these are actually very, very expensive. And oftentimes this drives a cardiology consultation so that we're trying to modify risk, right? So let's talk about statins. I talk about high intensity and low intensity statins. And so I printed off this summary so that you could see this. A high intensity statin is a reference to both the type of statin and the dosing that is used. So a torvastatin high dose or high intensity would be somewhere between 40 and 80 milligrams. But if you look down here at simvastatin, which is actually kind of a crappy statin, it's not that great. You have to take a much higher dose of simvastatin to be considered high intensity. Rosuvastatin, you need a little bit less. I'm not going to spend a ton of time on these. I just want you to know that there are guidelines that say what's a high intensity and a low intensity statin. And if you're Randy Vaudry, you also get very focused on what's considered lipophilic and hydrophilic. Now, what the heck does that mean? Lipophilic means that this cholesterol lowering medicine likes fatty tissue. It can migrate out of the bloodstream into fatty tissue and sit there. So lipophilic statins are more effective. They cross the cell membranes. They cross the blood-brain barrier. They actually get into the brain. But the problem with these statins is there's generally a higher rate of side effect and myopathy, or that dreaded leg pain. That's where people say, oh, my legs feel like they're so heavy. I walk up the stairs and it's like you put me in concrete shoes and I can't lift my legs. So there's a little bit more side effect risk associated with lipophilic statins versus the water soluble or hydrophobic or hydrophilic statins. They're water soluble, they function in the liver, and you don't necessarily store them as much. So whenever I write statins, I try to write these hydrophilic statins. Rosuvastatin is my drug of choice. Pravastatin is another one that I use. And why would we choose one over the other? Well, it's insurance. Oftentimes I can't get rosuvastatin approved first round. I have to start you on pravastatin and see how you do. Okay, so that's water soluble versus non-water soluble. And for years, we've done this Framingham risk assessment. You can go online, and if you just type Framingham risk assessment for coronary artery disease, you'll get a little table. It's a calculator that looks like this. Let me show this to you. You'll put your age in. I'm 52 years old. You'll declare your sex. I'm male. You'll declare whether or not you're a smoker. I'm not a smoker. You'll put in your total cholesterol. These are absolute values, right? My total cholesterol level was 202 at the time that I filled out this calculator. I look at my HDL cholesterol. My HDL cholesterol was 45. And what is your blood pressure? My systolic blood pressure was 122. These are actual measurements. Am I on blood pressure medicine? Nope, I don't need them yet. And so then you calculate your risk reduction and it tells you what is your 10-year risk of death or your 10-year risk of a heart attack, right? This is a mathematical model that was established by Framingham. I have a 5% risk of death somewhere in the next 10 years. Sound morbid? Well, guess what? All of the calculations in cardiology are we get aggressive when your risk is greater than 10%. When you have a 10% or greater risk of death somewhere in the 10 years, then we get more aggressive. That's just what happens in cardiology. Now, what this does not calculate, remember, our whole goal is a preventive cardiology factor. We have based all of our cardiology guidelines on these risk factors, but here's what it doesn't account for. There's no question about do you exercise or sedentary? It doesn't ask us what's your blood sugar or your insulin level, or are you diabetic or insulin resistant? There's no inquiry about your family history, because if your dad died of a heart attack at age 45, your risk obviously goes up, probably just from genetics. There's no inquiry about hormone replacement. Women, I want you to listen up. Did you know that your rate of heart disease is far less than men while you're menstruating? But after menopause, your risk of heart disease is equivalent to men. There is a protective effect of estrogen, progesterone, testosterone, pregnenolone, DHEA, all of those hormones, right? Which is part of what drives me crazy when we disparage hormones and say they're risky. My gosh, it's actually cardiovascular protective for all of our women. What diet are you on? This Framingham risk assessment doesn't inquire about your diet. It doesn't inquire about your weight. It doesn't inquire about your health. We just learned that if you have rheumatoid arthritis, you have greater risk of heart disease. If you have liver disease, you have greater risk of heart disease. If you have any form of autoimmunity or gout or other inflammatory disorders, your risk goes up. It doesn't ask us if we have autoimmunity or if you've ever had a blood clot. Look, I have people that go on a long vacation, they get on a plane and they get to their destination, they have a blood clot when they're sedentary. That's a risk factor for cardiovascular disease, but this Framingham questionnaire doesn't inquire about that. It doesn't inquire about past events. Did you have a stroke? Do you have Raynaud's phenomenon? Have you ever had vasculitis? So I don't know what the blood vessel health is. I don't know what your CRP is. I don't know your history of blood clots. There's no inquiry about your omega-6-3 ratio. There's no inquiry about your uric acid ratio, right? Uric acid is a predictor of heart disease. It doesn't ask me if you have sleep apnea. Do you realize that your rate of heart disease goes up if you have sleep apnea? It doesn't ask me anything about your homocysteine level. There's no inquiry about CRP, whether or not you've had a coronary artery calcium score. I don't know if you go to the dentist and you have gingivitis or periodontal disease. Wait, what? So we've been basing a risk factor of heart disease based on your total cholesterol and your blood pressure and your sex and age. And yet there's all of these other predictive models about whether or not you're going to have a heart attack. Can you see why I established a lecture series called Preventive Cardiology? Because I want to address all of these with my clients. They come in and they say, well, my cholesterol was a little bit high. And my response is, yeah, guess what? That's not a very good predictor. We need to look at all of these elements and put together a comprehensive and integrative plan to help you minimize your risk of heart disease. Okay, so what? Well, I started teaching modules. And over time, my plan is to share some of these modules with you. High blood pressure is module 1. Meaning that when we go through a preventive cardiology program, I'm going to spend some time helping you understand what your high blood pressure is. Let me give you a story. Yesterday in my office, a young lady came in that had a stroke in February. She's 66 years old. She's diabetic. She's menopausal. She has a stationary lifestyle. Her A1C is elevated. She has all these risks. and she had a stroke. Now, I've taken care of her for 10 years, and she always says, I'm a natural person. I don't want cholesterol lowering medicine. But yet she's been unwilling to get off her butt and go exercise. She hasn't lost any weight. She's lazy on her diet. She's eating sugar all the time. In fact, her A1C in April was 9.0. Okay, so guess what? It's predictive. She had a stroke at age 66 years old and went to the emergency department. Fortunately, it was a mild enough stroke that she doesn't have one-sided weakness. She gained all of her speech back. Her brain fog has gone away. But guess what it did? It actually turned the lights on. Now she's finally recognizing, oh, good grief, I'm in trouble. And so I have seen her every month, and we are managing her blood pressure. Now, if I'd attempted to give her a blood pressure medicine, she would have said, no way, Jose, I'm not doing blood pressure. I'm all natural. Well, now that she's had a stroke, she comes in and she says, Randy, I can't get my blood pressure down. I'm like in systolic 160. Yesterday, I started my third drug. She's now on 3 drugs, atorvastatin, lisinopril, and carvedilol. And all we do is keep raising the doses. Why? Because she's still trying to get her blood sugar under control. And she tells me, I'm too tired. I don't have the energy to go on a walk. I can't exercise. You see how complex this is. Now, I could have said to you, I could have used her as the story that I failed her. But the truth is, I haven't failed her. I have been very aggressive at trying to lower these risk factors. And she's just been a little bit more cavalier about it. Well, I'm not her mother. And I don't force anybody to do anything, right? So when she comes, I don't guilt trip her. I just give her this paper and I say, hey, look, these are all the things. I've invited you to do these. Whether or not you do them is your choice. Well, she finally conceded to start cholesterol lowering medicine. She's on that. She's on a blood thinner now, right? So this is what we talk about. So high blood pressure, homocysteine, history of vascular health, dysautonomia, and a D-dimer, right? I look at that. I want to know what's your risk of a clot? What's your CRP? What's your uric acid level? The whole world looks at uric acid level in the context of gout. Is it high enough to cause gout, or is it low enough I don't have gout when I get joint pain? Did you know that your uric acid level is a predictor of heart disease? In fact, within the last couple of years, one of the treatments for gout called colchicine now has an indication of treating heart disease. And individuals start colchicine to try to lower their uric acid levels because when uric acid levels are at lower levels, they have lower rates of cardiovascular disease and heart attack. We optimize hormones. The world still has not come to terms with the fact that estrogen protects the heart. Now, everyone that does hormone replacement therapy can quote those studies. We can talk to you about them. But the world of cardiology still doesn't get it. And if you talk about hormone replacement, they say, well, I don't know, maybe it's going to give you a risk of a blood clot. No, the risk of a blood clot comes from oral contraceptive pills, synthetic progestins, right? So this is where the world is goofy there. So this entire module, I taught about optimizing hormone replacement to reduce the risk of cardiovascular disease. Get a coronary artery calcium score. Everyone listening to me today in the neurological lecture needs to go to your local hospital and get a coronary artery calcium scan as a predictive measurement. I've done it every year for the last 3 years. I'm happy to report my score is 0. That's what I want. That is a massive predictor of cardiovascular disease. Guess what? I don't even think you need a prescription to do it. And at my local hospital, that's a CT scan of the heart. It only costs $89. That's how important it is. What's your omega-6-3 ratio? Omegas are very cardiovascular preventive. What's your blood sugar, your A1C, and your metabolic health? My gosh, that is an early risk factor for heart disease. Cholesterol levels, I just talked about that today. Do I pay attention to it? Sure I do. Is it my sole focus and everyone just gets a statin? No, I'm looking at all of these other interventions. Dental health. Most people don't realize that when you have bad dental health, your risk of heart disease goes up dramatically. You'll start laying down plaque in your vessels of your coronary arteries because those bugs that are in your mouth will promote heart disease. Do you have obstructive sleep apnea? Are you snoring at night? My gosh, you got to fix that. That's a risk factor for heart disease. Have you had a concussion that's led to dysautonomia? Guess what, my friends? That leads to cardiovascular disease. It changes your blood pressure. It changes your heart rate. It can induce a little bit of dysautonomia and AFib. And then last but not least is your lifestyle, right? So each one of these comes with an entire lecture series. You can see this took me an entire day to work through this module with the physicians. So I pulled up this old tool chest, right? Here's a really cool carpenter tool chest from the good old days. Now, if you looked at a tool chest, it would all be power tools, but these are old tools for men and women who like to work with their hands. And here's what happened in cardiology over the last 10 years is we got hyper-focused on statins, which is just one tool. I'm not anti-statin or pro-statin. I just recognize it's a freaking tool. That's it. And for some reason, when we go to the doctor's office, that's the only tool that's talked about at reducing risk of heart disease. That's not my style. Look at all the other tools in the toolbox. That's why I talk about preventive cardiology. So as we get into our discussion, I want to give you a disclaimer. The first disclaimer is I'm not a cardiologist, and I recognize that there's cardiologists who might disagree with me. They would come at this maybe from a different standpoint. I'm okay with that. Do you remember during COVID, there was doctors that said, hey, look, you need to get vaccinated, you need to wear a mask, and we need to socially distance to stop this pandemic. And then there were other groups of doctors that said, hey, you need to make sure your vitamin D level is at least 70. You need to make sure your zinc level is greater than 100. You need to go outside and exercise and get sunlight and use some red light. And maybe if you get COVID, you start ivermectin as an off-label drug to calm inflammation. You remember those days, right? Well, guess what? Those two disciplines choked with each other. It was a head-on collision, and they canceled each other and disparaged each other for their lame approach. Sometimes that happens in this. A cardiologist might disagree with me. I'm okay with that. Disagree with me. Give me your argument. I'm going to give you mine. It's okay that we have differing opinions. My focus is going to have a very limited focus on cholesterol. Is it because I don't think it's important? No, I do think it's important, but I don't want to be just egocentric about statins. I don't want to be where that becomes the whole universe of our treatment protocol for cardiovascular disease. I'm not going to give an extensive review of the literature. I'm not going to say, well, this study says this and that study says that. This is not a literature review. It's designed to be a clinical review. It's to talk about what we do clinically. And I'm going to make some very well-established assumptions. These are not Randy Vaudry's assumptions. These are assumptions that have been made through clinical study that look at triggers of cardiovascular disease so that you can sit on the back end and say, now what am I going to do? Am I going to take hormone replacement therapy? Am I going to do a coronary artery calcium score? Am I going to take something to lower my uric acid level and lower my A1C? Okay, and it's not designed to be extensive or exhaustive. It's designed to be complementary and integrative. And I will make sure that we post on our community website a practical tool that lists all of these interventions in a one-page summary. You'll be able to print off one page that says, check all of these variables and make sure that we are lowering the risk of cardiovascular disease by doing these interventions. I've already made the summary. Here it is. Principles of preventive cardiology, and then I've given you a checklist. Control your blood pressure. Make sure your homocysteine level's been optimized. What are your vascular goals? And then on the back side of that page, I actually listed the values. Make sure your homocysteine is less than 8. We want it 7 or less, okay? And I do this through mini modules. So each one of these modules will address a different risk factor. Now, at A Mind for All Seasons, because we talk so much about brain health, I don't know that I'm going to do all of these in succession. I'll have to get your interest. You guys can let me know. You can post something on the chat, or you can say, yeah, Randy, please go through each one of these and walk us through that. I'd be happy to do that if that's what our community wants me to do. Okay. And with that being said, I'm going to end our slideshow and open this up for some discussions.